Hello everyone, this is Christina Smith, DNP student at Palm Beach Atlantic University. With April being Testicular Cancer Awareness Month, I found it fitting to present this case study to the group for the Week 12 VoiceThread discussion. This case presentation begins with a 35-year-old male with an isolated past medical history of cryptorchidism corrected at the age of 5. His current clinical presentation includes a painless enlargement of the left testy. During examination, the nodule is opaque on transillumination. A diagnostic ultrasound was ordered and shows soft tissue enlargement without a cystic component. Blood work was drawn and included a serum HCG of 90 milliunits per ml and an AFP of 7 nanograms per ml. Additional studies to mention are an abdominal CT that revealed para-aortic lymphadenopathy. This patient ultimately underwent left radical orchiectomy, in which a 4-centimeter nodular mass was removed. Radiotherapy to the abdominal retroperitoneal region was completed as a part of the recommended treatment. In review of cryptorchidism, it is often referred to as hidden testes, or sometimes better known as undescended testes. It is considered the most common congenital anomaly of the male genitalia and occurs in nearly 1% of boys who reach 1 year of age. Cryptorchidism is classified as a developmental defect wherein the testes fail to descend completely into the scrotum by 6 months of age. Known causes are often felt to be hereditary, hormonal, anatomical, or environmental. The gold standard for diagnosis continues to rely on physical exam. Early surgical intervention is recommended between ages 6 to 18 months to help prevent associated risk factors such as infertility, testicular malignancy, torsion, and trauma. Orchidopexy involves moving the undescended testicle into the scrotum and permanently fixating it there. Testicular cancer has a long-standing association with undescended testicles. Nearly 75% of testicular malignancies occur in the previously affected testicle. It is considered the most common cancer in young men 15 to 35 years of age. Those with surgical correction of cryptorchidism after the age of 13 have a significantly higher incidence of testicular cancer. Additional studies surrounding the development of testicular cancer have focused on other causative agents such as HPV infections, race, and ethnicity. Germinal cell tumors are the most frequent form of testicular cancer and can be divided into 2 groups: seminomas and non-seminomas. These two occur equally with many of the tumors consisting of both seminoma and non-seminoma cells. Seminoma testicular cancers are those that arise in the cells that produce sperm and are divided into 2 main subtypes, classical and spermatocytic. Classical seminoma tumors account for approximately 95% and usually occur in men between the ages of 25 and 45. Lymphatic spread is the most common method for dysplastic cells to migrate to other organs. Most often, the first symptom of testicular cancer is a painless lump on the testicle, or the testicle becomes swollen or enlarged. Transillumination of the scrotum helps to establish a diagnosis by looking for darkened areas that do not allow the passage of light. Imaging studies, such as a testicular ultrasound, are used to help with differential diagnoses among testicular masses and other benign conditions, such as a hydrocele. MRI and CAT scan are often helpful in detecting metastases. In this case, the abdominal CT demonstrated para-aortic lymphadenopathy, suggestive of potential metastatic involvement. Laboratory evaluation can also help diagnose testicular tumors. Many testicular cancers make high levels of certain proteins called tumor markers, such as alpha-fetoprotein and human chorionic gonadotropin. When these tumor markers are in the blood, it suggests that there is a testicular tumor. Rises in AFP or HCG can often help doctors tell which type of testicular cancer it might be. Seminomas occasionally raise HCG levels, but never AFP levels, as in this case. Therefore, any increase in AFP means that the tumor has a non-seminoma component. A testicular tumor might also increase the level of an enzyme called lactate dehydrogenase, wherein widespread metastases can be present. Testicular cancer has the highest survivability rate of all malignancies. There is a 95% survival rate after 5 years with early diagnosis and treatment. Metastases and high serum tumor markers are often associated with less optimal prognosis. However, despite this, survivability remains at greater than 80%. Many testicular cancers contain both seminoma and non-seminoma cells. These mixed germ cell tumors are treated as non-seminomas because they grow and spread like non-seminomas. Surgical removal of the testes is recommended in order to diagnose and stage the tumor. Biopsies are rarely done for a testicular tumor because it runs the risk of spreading the cancer. Most common forms of treatment for testicular cancer include surgery, chemotherapy, and radiotherapy. Continued medical follow-up should be encouraged as survivors of testicular cancer are at an increased risk of secondary cancer, among others. Additionally, those who receive treatment with radiation to the abdomen or pelvis are also at an increased risk of cancer developing in the radiation field. It is important to educate these individuals about the need for performing regular self-exams and reporting any new symptoms or changes in health. I hope that you found this case review informative, and I thank you for allowing me to share this with the group. Have a great day.